Hello and welcome to the Motivational Midwife. My name's Lynn Jones and today we're going to be looking at the Maternity Early Warning Score, or otherwise known as MEWS. So we're going to look at MEWS today. So what is it? Well, Maternity Early Warning System, which previously was known as the Modified Early Obstetric Warning System, or MEWS, we have actually used for quite some years. Bedside scoring system, so it helps us assess whether deterioration is happening or not. The issue we have is, of course, that general early warning systems are not suitable for pregnant clients because the parameters for pregnant women are different. So historically, what we've had is a lot of unnecessarily alerts. So women being alarmed and us escalating unnecessary on healthy pregnant women. So this was developed, the MEWS was developed to actually reflect a more general data from pregnant clients so that it can help us respond to those signs of deterioration, reduce those unnecessary triggers in healthy pregnant women compared to what has happened historically, which means that it will aid in appropriate escalation. It's important that we pick up early signs of deterioration, that we can monitor those vital signs antenatally, intrapartum and postnatally, and that it helps us have a more holistic picture so that if there is signs of deterioration, we can appropriately escalate early and reduce the negative impacts on our client base. So NHS England developed the peer system. So it's a framework that supports clinical personnel to actually think about the prevention of deterioration, the standardisation of language, supporting that timely intervention, and escalation appropriately, and then that response if you have got concerns about deterioration. And peer kind of goes very much in conjunction with MEWS. So how did it come about? Well, the 4P study, which was pregnancy physiology pattern prediction, Professor Peter Wilkinson and his team kind of developed this. They recognised that pregnancy affects the parameters, that we have different goalposts to work from when you're pregnant. So what the study actually did was take large numbers of pregnant women and they developed those normal ranges from the results of that large prospective study. And what the hope was that it should considerably reduce those alerts in healthy women compared to our existing MEWS system. The consistent evidence-based score and expert ratified escalation pathways mean that MEWS can be replicated in other healthcare systems as well. I will put a link to that study in the description below. So what sort of things have changed? Well, the parameters for the scores and escalations have changed. There's additional concerns that's added to that holistic approach. So even if all the parameters are actually within normal boundaries, if you have additional concerns or the woman herself has additional concerns, it will help with that holistic approach. And also the escalation procedure. So who's escalating to the appropriate people at the appropriate time. So all pregnant women from 5 weeks pregnancy up until 4 weeks postpartum should have any observations they have done in any healthcare setting recorded on a MEWS chart. So, for example, if you have someone that comes in via A&E with something unrelated to the pregnancy, their observations should still be recorded on a MEWS chart, not a general early warning scoring chart. And as you can see, this is divided into levels of concern with low, medium, and high. Then you've got the actual scores, and then who to escalate it to, or what your escalation pathway should be. So obviously, if it's a low concern, triage them or continue your care as planned, and then whatever the frequency is that you're currently doing, be that 4 hourly, carry on with that. If anything else creeps in, or the medical review comes outside of time, then obviously you will escalate up appropriately. So you can see you've got those parameters and who to escalate to, and timeframes to escalate within, and you'd move up to the next tier if you don't get that review within your. So say, for example, we are looking at a low medium, so a score of 2 to 4. Your midwife in charge, or nurse in charge, depending on the area they're in, will need to be review that client, and then they'll have a medical review that will be escalated up to a medical review that they should be done within 30 minutes. Okay, so that could be your SHO, your tier 1 SHO. And continue monitoring your vital signs every 30 minutes. However, if that medical review doesn't take place, so that SHO doesn't come within the 30 minutes, then escalate it up. So actually we now escalate up, so we're going to escalate up for more urgent review, and we want the tier 2, so a registrar or senior registrar, to come within 15 minutes to review this patient. So we're not waiting for that doctor to come and see. If they don't turn up within that 30 minutes, we are escalating quickly and promptly. So looking at our parameters, we can see that there have been some changes from what we've historically done. And this is taking into account that large prospective study that gave us a baseline for normal parameters within pregnancy. So you can see our normal parameters for respirations are 9 to 21. Oxygen saturation is above 95%. Temperature, now that has altered very slightly, because it used to be sort of up to 37.5, you wouldn't get too excited about, but you can see that that temperature has altered slightly. And our pulse. So we've got a normal range that goes higher than we historically have had. So 112 could still sit within a normal range. But again, you're going to be taking this as a completely holistic view, and so you take the bigger picture. And if she is a bit more tachycardic, we want to know what else is going on. And it could be that she's suffering from anemia, which has made her a bit more tachycardic. Critically, we have a change to the parameters for postnatally. So 48 hours post-birth, you'll notice that the ranges change dramatically. So up until 48 hours, we can use the 71 to 112 beats per minute as our normal parameters. But from postnatal, 48 hours postnatally, that significantly reduces to 58 to 98 before it will trigger. Changes in our blood pressure monitoring as well. Our parameters for systolic blood pressure, the systolics reduced, the upper ends of that is reduced to 135, whereas it used to be 140. And the diastolic, again, is down to 88, where we used to kind of have a bit of a cut-off at 90. And you can see underneath we've got those additional concerns. So, you know, are you as a healthcare professional worried? Is the woman worried? Are there other things that are going on? So is she needing oxygen to actually maintain her saturations? Has she got severe hypertension? Is there pain there? Is that pain getting worse? Is there any vaginal bleeding? Is there any reduced urine output? Or is there any change to her level of consciousness or response? So these are additional concerns that would equally trigger on your MEWS. So our thresholds and triggers, and again, this is just a slightly more detailed picture of that level of escalation that I showed you earlier in the presentation. And again, it depends in the grade of your team member that you want will very much depend on what it is you are needing and on the local skill mix within that organisation. And you can see at the bottom here, we've got that when that primary team member is contacted. So say you're ringing the SHO and they're not coming, then you need to escalate to that secondary contact very quickly. Okay, you'd expect that secondary contact to attend within that initial period of time. So if you've rung the SHO and they sort of say to you, I'm really sorry, I can't get there, immediately you can ring the registrar and ask them to attend, so that the woman within that 30 minutes for the first review. And also, obviously, for the postnatal women, you need to use the time and date from which these values should be used, and you need to enter that on the, if you're using paper charts, on the front of the chart. If you've got electronic charts, then the hope is that your system will automatically change that, so that from 48 hours post-birth, the different parameters should kick in. So when are we using it? So antenatally, so anybody that is pregnant from 5 weeks pregnant throughout the whole pregnancy up to 4 weeks postnatally. So, essentially the level of time that we as midwives care for women, that is the time that we should be using the MEWS chart and not MEWS and not general use charts. So in labour, you'd do a MEWS to give you an initial baseline, and then every 4 hours in labour you want to really do that holistic picture, and in between times think, is there any clinical indication that I really need to do a full set of observations, a full MEWS, and not just a pulse or a blood pressure. So in conclusion, what does MEWS do? Well, it identifies those people at risk of deteriorating much earlier, which in itself then will aid in early escalation, but escalation to the correct people. Think also clinical indications, so don't wait for your 4 hours before you repeat a full MEWS. If you're not happy about something or you're concerned, then do a full set of, do a full MEWS assessment. It will give you some guidance as to whether or not you want to take this further or not. But even if all the scores are within normal limits, remember you have that additional concerns box. So if you are concerned about something, then you escalate appropriately at that point. Don't wait until there is actually a MEWS score that will trigger. Documentation, it's really important under our NMC guidance that we document as contemporaneously as possible. If you've got paper documentation, then obviously complete your charts accurately. Make sure they're signed and dated, and times are accurate on them. If you have electronic systems, then make sure they're completed. They tend to be quite tick boxy, your electronic systems. So, think about adding some more context in your contemporaneous notes. So your clinical notes, add a little bit more context to the whole situation. It just makes for better documentation and more holistic documentation. And remember, as an NMC registrant, you are accountable for your own practice. So you need to make sure that you are actually following guidance and undertaking things as per the correct procedures and escalating appropriately. So thank you. And so there you have it, a quick whistle-stop tour through MEWS. I hope you found that useful, and I hope that you found that the changes from MEWS to MEWS are fairly obvious, and that it will actually aid your practice going forward. If you haven't subscribed to the channel, please do so, and I look forward to seeing you next time.